Hello friends, this is Dr. R.B. Kushoha, Associate Professor in the Division of Veterinary Clinical Complex at FVSC and AH Scott Jammu RSpura. Welcome to my YouTube channel, and if you are new to my channel, so kindly subscribe the channel and hit the bell icon for further notification. So today we have a case of intestinal obstruction. So this cow is presented with the history of not passing dung from the last 7 days and had Kolki sign, that is abdominal pain 7 days back, and it's not taking feed and fodder from the last 7 days, but animal is taking little bit water. If the cow presented with the history of not passing feces and the Kolki sign, so we suspect for the intestinal obstruction. Since here incidence of intussusception is very high, so we always suspect for the intussusception. But before confirmatory diagnosis of intussusception, first we go for the rectal examination and then go for the ultrasonography. If the rectal examination reveal the mass, then it's fine. Otherwise, we go for the ultrasonography just to see the distended loops of intestine. This is a 2.5-year-old cow. So before going rectal examination, also we can perform rectal examination without epidural, but I have given this epidural analgesia so that I could insert the hand very easily. So whenever we go for the rectal examination, so we should not confuse with this kidney. So we should always go for the examination in this right abdominal side. So here the standard loops of intestine is palpable. Although it is not grasped by the fingertips, the mass is palpable. So it is a confirmed case of intussusception. So this rectum is also empty. So this is the one of the sign of the intussusception, that you will find the rectum empty. So sometimes it is, you can say, this mucus plug, it is a cream colored mucus plug, or if it is very old, then sometimes greasy appearance also. So you could see, so this is all mucus plug. So this is the indication of that this is rectum is empty. This is a confirmed case of intussusception by the rectal examination. So we will not go for the ultrasonographic examination. So now next step is we go for the right flank laparotomy. So now we have prepared this right flank side for the laparotomy. So this is the right paralumbar fossa. So this is the last rib. This is the transverse process of lumbar vertebrae. So we have injected the 2% lignocaine hydrochloride solution here linearly. So we have given the linear infiltration. So make an incision from here to here. So we give a skin incision. Then we incise these muscles. Then we cut the muscles here. Then receive the another layer of muscle. So basically here external and internal obliquus abdominis. Then this is the transverse fascia, and this one is the peritoneum. Give the least tissue for a sec. So this is the peritoneum. So just to prevent the bleeding little bit, we just put the drape like this and we just hold for few seconds like this. So definitely whatever the capillary bleeding, that will stop automatically. So now after performing the laparotomy, now you could see this is the omentum, it is all covered the intestine. So now for externalization of the mass, so we insert the hand like this and then reflect the omentum. So this is the omentum, we reflect cranially like this. So this is the fold of. So once you reflect, now you could see the serosal surface of intestine. Now you could see the how distended this intestine. So this is a clear cut indication that this is the intestinal obstruction, because in intestinal obstruction there is a distension of the anterior loop. So now I grasp this, because I have already palpated per rectally, that it is cranial to the pelvic brim towards the ventral side. So I have grasped this mass. Now you could see, now I am extruding this mass. So now you could see, so this is the intussusception mass.
Yeah.
So this is a 7 days old. Now you could see start here. If there is a adhesion little bit here, there is a adhesion here. So if I pull, so definitely it will tear. Now you could see even during the extrusion, this one basically was like this. So because of the separation here, so there is a oozing of the blood. So now it is clearly indicated that this one is the distal part, which is collapsed, this one. And now you could see this intussusception, the telescopy part is gone up to here, and this is the part which goes inside. So this is the mass, this is the distal intestine, and this one, this is the basically mesentery. And if you see, so this one, this is the intestine, this one, this is the anterior portion of this is the intestine, this is the anterior. So you could see here after this, so there is a here, okay, if you see, so this is gone basically, this is the adhere, so this one is adhered here like this. So this is basically gone inside from here and then goes here. Just to show like this, so if I pull like this, so yes, so this is the now it is clear. This is the anterior part and this is the posterior, and we have to resect from like this. So next step, we just pack, and we just see here, this is the swelling of the, this is the mesentery, this is all, this is mesenteric lymph node, this is mesenteric blood vessels, this is blood vessels, these are blood vessels. So next step, we pack this one with the sterile drape, and then just to abolish the pain during ligature of this mesenteric blood vessels and cutting, we infiltrate the lignocaine here. So that is called the mesenteric blockade. So we go for the mesenteric blockade. So we just inject the 2% lignocaine hydrochloride solution like this. So this is puncture the blood vessels, that is here little bit oozing. So this is the 21 gauge needle, so that is why it's going very slowly. So this is all about this blockade. So now next step is we just packed this incision with the drape. So we always moisten this drape so that it won't stick or adhere with the organ. That is sufficient. So now in this way, and then we apply the one here forceps. So we just apply leech tissue forceps. So now it will easy for the further procedure. So most important problem is this mesentery, which is gone inside, and this is this swollen mesentery. Okay, hold like this. So before going to application of the intestinal Doyne's clamp, so we should see the diameter of the intestine on either side. So here luckily the diameter is almost same. So this is the, so we apply here. This is the at distal extremity. So here you could see here, this is the polyps, this is the intramural. So this could be the region for the intussusception. So intussusception occur due to any region, yeah, due to any things which alter the motility of the intestine. So anything which alter the motility, that may lead. So you could see here, this is the polyp. So it is better to we excise this portion also. So it is better to take from the healthy area. This is the one clamp, and this is the another clamp. Just hold from here, leave it this one. So now next procedure is, so we ligate this mesenteric blood vessels like this and like this. Please someone give number 1 polygalactin 910. Please cut it. So this is the advantage of mesenteric blockade, that animal doesn't feel pain while suturing. Keep finger one like this, okay? Yeah. Then now we start from this distal end here. So first we apply these blood vessels. So we are lucky here that today there is no pain. If it is otherwise, in most of the cases animal feel severe pain while this procedure. Cut only one end. Now we mop it here. So now you could see, so this is the distal segment, this is the proximal segment, this is the distal segment, this is the proximal, and we have to cut from here to here. So we ligated the blood vessels, mesenteric blood vessels, like this. So when we cut like this, it form a triangular, and then remaining portion we suture, and then we go for the into anastomosis of the resected intestine. So next step is to cut the, so whenever we start cutting, so better to start from this collapse end, because in collapse ends the content is not present, so better to leave the, you can say, few mm. So now this one is the reverse bleeding, so we should not worried about that bleeding. And then cut from the hair. So whenever we cut from here, so in this way we have resected. So we should not leave this portion immediately, otherwise so hold from here, give the mop. So now you could see, so this is the two end, and we have to repair this one. So little bit bleeding is here. Give artery forceps, please. Now you could see here there is a disparity in the lumen of the intestine. So definitely we make this one in slant after mesenteric ligature. You hold from here with one hand, this one also. Leave this one, no? You hold this one. So you see, this is the cut portion of the mesenteric lymph node. So now we see this one is relatively small and this one is large. So whenever we take the bite, so here we take the bite towards the narrow and here the greater, so that we can like this. Then we release this. So we hold this one and make a slightly angle form, so that the diameter become equal. So now we cut this one with the suture. Mop. So now diameter is almost equal, you could see. So this is the lumen of the distal segment and this is the lumen of the proximal segment. So now we are going to perform the most important part of the intussusception, that is the anastomosis. So we always take the bite from the mesenteric border and take the lumen from of the one of the segment and then insert from the inside outside like this. So this is the 2-0 polygalactic 910. So minimum 4th row. So now take the this from the this is the mucosa of the this proximal and then this is the serosa and then coming through the mucosa. Then again this is the mucosa, serosa, serosa and mucosa. Again here full thickness means this is the mucosa, then serosa, then the serosa of the other side, then the mucosa. So this is the simple continuous pattern. So this is the full thickness of the one side, then again on the here. So whenever we take the bite, care should be taken that it should not anchor the wall of the other side. So if it will peer here, so it will block the lumen. This is the simple continuous pattern. So half of the portion of the first layer of the lumen we approach I take the bite from mucosa to mucosa, and then the rest of the half from serosa to serosa. So here it is difficult to take, so better to take the bite individually. So now we are approaching towards the other side. So now from here onward we take the bite from serosa like this, then coming from this mucosa and out from this serosa. So this is the simple continuous again. This is the most important part because the outcome of the intestinal surgery depends on this how beautifully you perform the anastomosis. So this is the second half of this lumen. This is still, it is the first layer. Mop. So while taking the bite of this second half, care should be taken that the tip of the needle should not puncture the below structure. Otherwise, if it is puncture the below structure, that means it will again block the lumen. So now you could see we are almost approached at the side from where we have started. So this is the, then we again you can say close. So this is the first layer we have completed. Now at this point there is difference in the opinion. So some surgeon they go for the second layer application with the clamp in place, but I used to prefer we remove the clamp. So I first remove this distal clamp. So now you could see this is the non-crushing, so that is why even after application there is no damage. Then I will, now you could see how the distension is in the proximal segment, just because the content is ready to go towards this distal. So it will also tell about this how beautifully you have applied your first layer. Now you could see the content is going. Even if some little bit leakage, don't worry, because we apply the second layer also. Now you could see, so content is going in the distal, slight leakage is here, so definitely that will be repair in the second layer. So this is a clear cut indication that this repair has been done nicely. Slight leakage is here, so we will manage. So hold like this. Just give the mop. So doing this surgery in the large animal is very difficult, particularly keeping the all things aseptic precaution. Animal should not move, even the position of the surgeon and assistants. So this all counts in the outcome of this. So we are lucky here today that this animal is very cooperative, or in other words you can say the analgesia part we have managed very nicely. So this is the second layer. So second layer, it is basically the Cushing pattern that is bite parallel to the incision or parallel to this first layer. So you could see we should not take the bite throughout this layer of the intestine. Only we pierce in this submucosa just below the serosa. So only care should be taken that we should not pull tightly, otherwise what happened? So there is a narrowing of this intestine. Here. Yeah, this much is sufficient. This much. pour the distilled water, give the mop. You hold like this, just leave this one, first hold like this, okay, like this. So now you could see there is a contraction. So this is the distal, so distal portion is very narrow. Now you could see how carefully I am taking the bite. We should not puncture this all layer, only superficial, just to oppose this, yeah, like this. So this is the time taking procedure but important one. This is the portion from where the leakage, mild leakage was there. So we will take a bite so that it will invert. Mop. So once you release the clamp and you go for the second layer, so it will also tell you about whether you are taking the bite in full thickness or partial, because in full thickness definitely there will be leakage of the content from the pierced area. So now almost we are completed the second layer also. So this is the probably now have entered the mesenteric portion also, so there is no harm to repair this one also. And then take the bite from here and just reverse, so that you again come at the same point from where we have started. Yeah, like this. So we'll also repair this mesenteric portion which we have left in the beginning. Give the mock. So now you could see this is the repaired portion. So this milking. So if you release this one, okay. Now you could see how beautifully this content is going. So this one is because this one is compressed by the release tissue forceps. Now I will show you just this. You could see. So now content is going from this. So this is the repaired portion, and now content is going from this proximal to the distal. And the most important, no leakage, nothing. You could see here. So we'll wash this one, release this drape, and then go for the closure of the laparotomy incision. Please somebody put normal saline. Wait. So we try to remove this little bit blood clot which adhere over the serosal surface of the intestine, and then and in the beginning we should count that how many drape you have inserted in the peritoneal cavity. So we have inserted only one. So now we replace this intestine back into the original position, and then whatever this momentum which we reflected back, this one, so we cover again like this, and then pull and then replace like this. So now you could see this is the only again momentum. So next step is closure of this muscle. So we repair these muscles in the single layer. So we take the bite, we start from the proximally. So closure of laparotomy incision is as routine, nothing special. The only difference that some surgeon they prefer to for the peritoneum layer separate and the muscle layer separately, but here I repair in the single layer. So this is the peritoneum. This is the peritoneum. So we always keep the finger inside just to prevent the anchoring of the needle with the intestine or some other structure. Here now it is very difficult to, so even if you only take the bite only in the muscles layer, that will also sufficient. Now in this way we have closed the here I am not putting the artery forceps, because if artery forceps I put, it will fall like this. So either somebody pull like this. It is only in the small animal where animal is laterally commencing. So today we are on the verge of the completion of this procedure in the standing position. Otherwise, in most of the cases during the half of the procedure, animal fall down and attain the laterally commencing. So now we can take the bite, go for this subcuticular or the second bite. So I used to prefer in the combined. So take the bite like this just to obliterate the dead space. So now we are going to start this suturing of the skin. So I used to prefer this simple interrupted pattern. Otherwise you can go for the even cross mattress or horizontal mattress. So this is the switched on needle. So we make this needle with this 18 gauge hypodermic needle, and how to make this switched on I have already uploaded on my YouTube video. So I will give the link, so you could see that link if you want to see how to make this switched on needle with hypodermic. So in this way we have applied the simple interrupted suture pattern on the skin. So you could see, so the skin edges are exactly in the position, so there is no eversion or inversion of this skin edges. So this is all about the complete procedure of the intestinal intussusception in a 2.5-year-old cow. So we finished the surgery in evening around 5 o'clock, and on the same day after 3 hours cow passed the loose feces. As you could see, loose feces on the ground. But after 3 days owner sent the picture of the feces. The consistency of feces changed from the loose to the solid and in plated form. So thank you very much for watching the video, and if you like this video, so kindly share with your friends and subscribe the channel if you have not subscribed it. Thank you very much.